So I'd like to invite Gavin Giovannoni to the stage. We are delighted to have Gavin with us today and really excited to hear what he has to say. So.
Is it okay? Oh, thank you. I did change my slides. I took a few out and added a few. So thank you for inviting me. I'm talking to you today about going beyond what we would call focal inflammation. So there has been some discussion already about relapses and MRI activity. So as a neurologist looking after people with MS, when we talk about MRI activity, we talk about new lesions. And our therapeutic target has been to stop relapses and new lesions. But because of the smoldering processes, we have to go beyond that. And that's what this discussion is about, some of the issues. Just to say, I've got a large number of disclosures. I've been in MS field for 30 years now, and the only way we can improve things is by doing therapeutic trials of new agents, and unfortunately the cost of developing these agents are so high that you have to have the pharmaceutical industry. So I've been involved in many trials, and I will talk about some specific therapies today. So the evidence is very good. So this is actually data from one single region of northern Italy, Brescia, where they've been using exactly the same protocol to collect data for decades. And you can see that if you were born, if you had MS in those, what we call the pre-DMT era, by the time you got to 65, over 80% of people needed a walking stick, okay? The next era is the low efficacy. This was the injectables, essentially interferon beta and Copaxone. And there is an improvement. It's dropped to around about 65%, but it's not ideal, is it? And in the new high efficacy era, it's down to about a quarter of patients getting to 65. So there has definitely been an improvement in the outcome. What's not captured here has also been a change in the way we practice neurology, and people are getting diagnosed earlier and put onto treatment earlier. So what's not captured in this diagram is an earlier diagnosis, earlier treatment. And this is data from now the Swedish registry. So the Swedish registry is really important because almost everybody with MS who lives in Sweden gets into this registry. So it's kind of like a population, country-based study. And it just shows you in the Swedish registry, if you get onto a therapy within 1 year of symptom onset. Okay, and this is time to EDSS, what we call 4. So 4 is like a marker for secondary progressive disease. Once people hit EDSS 4, it's kind of like when you become progressive. And you can see that people get onto it. You can see the months there, up to 200 months. 86% of people were still without getting to EDSS 4 if they got it in first year. And if you had to wait 3 years after symptom onset, it dropped to 70%. So there is a difference there, and shows you how important time is in this disease. And I think time is important across all therapies. It's not just licensed therapies, it's also clearly a prognostic factor, even for HSCT. And so this is one of the reasons why we launched an international policy initiative back in 2015, because there was clearly a lot of variability across Europe and even within countries, within the UK, between access to treatments and early intervention. And we made this point that time is brain and time is spinal cord. And I think we've actually got there now. I think there's very few people in the MS community, or at least in neurologists looking after, that doesn't think time is important. The problem we have in the NHS is it's a resource issue. So we still have enormous delays in getting into the system. And I had one story a little while back of somebody taking up to 4 years to get into an MS service, which is shocking in the current era. But what's now emerged since the 2015 policy initiative, it's not only about time, but it's also about efficacy. And so this is actually an international study done by a database called MS-Base. There's over 150,000 patients in this database from all over the world. And they divided up the people into those that got onto what we call top tier of therapy. And this is not HSCT. This is fingolimod, natalizumab, and alemtuzumab. So this was done before the anti-CD20s were available. And the bottom tier would be the injectables and the first few orals that came out. And you can see the top graph is from commencement to therapy, and this is looking at disability progression. And you can see those who got onto high efficacy therapies very early, okay, did much, much better than those that got onto it late. And the bottom curve is actually waiting 6 years before you're getting onto these treatments, and you can see the efficacy, the effectiveness of these treatments drops quite dramatically. And what happens is the gap between the two disappears. So this is not only an issue about time, but it's also an issue about more effective therapy. And so this is why it's been driving the next phase of MS therapy, is that if you do get multiple sclerosis, you really should be given the option of being offered a high efficacy therapy, what we call top tier therapy, first line. And I think HSCT falls into that bracket, and it's one of the reasons why we're testing in the STAR-MS trial in the most active patients. You can get into the trial first line. And I'm not going to review this, but this just shows you that there's a big gap between, and this is in terms of disease activity. You can see these two review papers. This is Maria Piersamani, and that's Paula Morara's paper, just showing you how superior in these analyses. This is looking at freedom of activity, so no relapses, MRI activity, or worsening, according to the different therapies. And it's quite clear that HSCT sits higher compared to the others. So I don't think there's a question around efficacy. It's more around access and safety. And so now we're trying to push this concept of flipping the pyramid. So I don't know if you're aware, there are currently trials running in the world where they're comparing what we call maintenance escalation. People go on to a low efficacy, then have to fail it and then move up, versus flipping the pyramid. And there's two pragmatic trials running. The UK is part of one of the trials. And I personally think that's completely unethical now, with all the data we have showing you that high efficacy therapies are more effective than low efficacy therapies, randomizing people to that choice, without giving them the option of choosing between those. The other thing that's changed is our treatment target. So this is actually now a post hoc. So this is when, after the trial's finished, you go back in and look at the data. And this is from one of the anti-CD20. We heard about ocrelizumab. The trade name is Ocrevus. And in that trial, the drug was compared to Rebif, interferon beta-1a. That was given 3 times a week. And clearly the therapy wasn't 100% effective because people did get worse. So this is worsening of disability. And you can see that even with interferon, R stands for worsening after relapse. So people do acquire disability because of poor recovery from relapses. And then people also acquire disability outside of relapses, and that's the smoldering MS, what we call PIRA. And interferons, you can see 78, almost 80% of the worsening was independent of relapse activity. And with ocrelizumab, 1 in 5 people still got worse on the trial, but the majority, 90% was independent of relapse activity. And that's what we call smoldering MS. Okay, and so that's the process that we have to start targeting. We don't really have any therapies licensed at this point in time that we know for sure works on smoldering MS. And there are a lot of processes we think that are going on in this inside the brain and spinal cord that are driving this process called smoldering MS. And so that's why our treatment target has evolved. So in the past, we were happy just reducing the number of relapses, and that's exactly how interferon and Copaxone and glutaraimab got licensed, by reducing relapses. And then we got more aggressive when we wanted people to be free of activity, and now we're going way beyond that. We're also now wanting our patients to have a disability improvement, and we're also trying to manage them. We're trying to manage you more holistically to try and help with brain health. And some of us want to go even further. We want to actually scrub the brain clean of all these processes, or switch off these processes within the brain that are driving smoldering processes. And that's kind of why we've got clinical trials going on now, where we're adding on top of existing therapies, new treatments to try and scrub the brain clean. of, for example, the B cells that we think may be producing immunoglobulin antibodies that are causing the smoldering process. So we actually got a trial running at the moment with a drug from oncology. It's a thing called a proteasome inhibitor. So this is a drug that's licensed to treat a condition called myeloma, a cancer of plasma cells. And it clogs up the plasma cell and the plasma cell dies. And we're testing it as an add-on therapy in MS to try and get rid of oligoclonal bands. This is not without proof. There's a lot of off-label use of this class of drug to treat autoimmune diseases. And there have been quite successful responses with proteasome inhibitors as add-on therapies. Now, most people in MS think about, most neurologists who work in the space classify MS into 3 tiers. There's tier 1, what we would call moderate efficacy, tier 2, intermediate, and then tier 3 is high. I actually think there's the 4th tier, and this is where I would put alemtuzumab and HSCT. And the reason why I say that is it's the only, those 2 therapies, what I call immune reconstitution therapies, because they deplete the immune system and allow it to come back, are the only ones that actually normalize, or particularly when used early, normalize the accelerated brain volume loss that occurs in MS. So the brain volume loss that occurs in MS is probably is a marker of the accumulation of damage that's occurring across the nervous system. And people with multiple sclerosis are known to have accelerated brain volume loss. Actually, almost all neurodegenerative diseases cause the brain to shrink more quickly. I say more quickly because everybody after the age of 35 has a shrinking brain, okay? That's part of life, that's aging, okay? And that's, we weren't meant to live to 75 from an evolutionary perspective. So, aging is a disease in a sense. We all notice it. Our balance goes off, our vision, our hearing goes off, our cognition goes off, and that's just aging. Okay? People with multiple sclerosis are doing it much more quickly. And I do think we can make an argument that some people, depending how you define a cure, who go into long-term remission, I'm talking about 10, 15, 20 years after having alemtuzumab, Lemtrada, or HSCT, that appear to be aging in a normal way without any evidence of MS. And the question is, when do we define that as being a cure? And that's a big debate in the field, is how do we define a cure? If we don't define a cure, we can't find it. Okay. So this is what happens in MS. It's a big range. Not everybody shrinks quickly. Some people shrink very slowly and others very quickly. But we do know that the brain volume loss that occurs in people with MS is associated with poor outcome. Those people who have very rapid brain volume loss are much more likely to become disabled. They're much more likely to have cognitive impairment, to become unemployed, and to have a lot of hidden symptoms of the disease. So it is a big, big problem. And the good news is we have 2 treatment classes, alemtuzumab and HSCT, that pseudo-normalize this. I say pseudo-normalize because we'd never included normal age-matched controls in this trial, so we're using it based on what we know from the general population. But again, it's age-related, so this is just showing you, this is the alemtuzumab patients in the CARE MS up to 8 years. And you can see the younger you are, the less brain volume loss you've got, and we think age is a predictor here, but this rate here is under 0.1% per annum. Okay, and this is the interferon arm, so you can see the deficit you take when you go on interferon. Just 2 years of interferon leaves you with a much smaller brain than having gone on to alemtuzumab first line. And we've got similar data. This is just the Canadian data set. This is looking at the HSCT data set. Now this is slightly different because in Canada they use the myeloablative protocol. So this was a much more aggressive protocol to ablate the immune system. And what happens is in the first 6 months, there's quite a big shrinkage of the brain. And the reason for that is because of the inflammation gets suppressed, so you get the swelling of the brain goes away. It's called pseudoatrophy. But also the type of chemotherapy they use in this protocol is neurotoxic. And so it hits the brain, and the brain takes a deficit from the chemotherapy. So you must be aware that there is this concept called chemo brain. So you might know about it. It typically occurs in older people who have aggressive chemotherapy for cancers, particularly ovarian cancer, for example. And the type of chemotherapy causes chemobrain. People can get quite confused and even come out with cognitive impairment. And you can actually measure it. We have a protein in the blood called neurofilament that we use in MS. And when you have chemotherapy, the neurofilament levels go very high. And in this particular cohort, they've published data showing you that when they had this big period of shrinkage of the brain, the neurofilament levels went up, implying that there was neurotoxicity. The chemotherapy was toxic to the brain. Maybe that's another reason not to use ablative chemotherapy, but to rather use a non-myeloablative protocol that's not that aggressive. But after that episode, those brain volume loss figures there are also under 0.1% per annum, which is in what we expect the normal range. Okay. So there are different levels. Now below that tier 4, if you go to tier 3, on things like ocrelizumab, the brain volume loss is in between 0.3 and 0.4% per annum. That's not normal. Okay? So this is one of the reasons why we're selling you a curved ball, in the sense that although we can put you onto these mid-tier therapies and stop you having relapses and your lesions on the MRI scan, we are not normalizing the brain volume loss. We're not getting into the central nervous system to tackle that smoldering pathology. Now, the other issue in MS, and it happens in all fields, is what I call a gambler's dilemma. And the gambler's dilemma is how you interpret risk. So when neurologists talk to patients with MS, people with MS, they mainly talk about the risks and benefits of the treatment. It's very unusual for somebody to be told about the risks of having MS. And when you understand the risks of having untreated or undertreated MS, it is pretty scary to understand that. And I think it's unfair not to talk about the risks of having the disease when talking about the risks and benefits of treatment. And we know MS, if left alone or not treated properly, has an enormous consequence for individuals. You know, in Europe, 50% of people with MS are unemployed 10 years after diagnosis. 50%. Okay, it cuts survival by about 5 years now, which used to be higher than that. There's an increased mortality associated with it due to underlying mental health issues. There's a big problem around relationships with this disease. None of this gets told to patients when they are making their decisions about their treatment, which I think is necessary. So when we discuss benefit and risks, we should really be putting what MS looks like on that table as well. And so this is one of the problems we have, is that when we as clinicians prescribing therapies, we have no idea who's going to respond. And so this is why a lot of neurologists are reluctant to use high efficacy or more risky therapies. And the issue is around the so-called gambler's dilemma. And the gambler's dilemma is very simple. When I don't know, anybody going to casinos in this room? When people go to casinos, they're never going to lose. They're always going to win. But we know only 3 to 4% of people actually win in a casino, 96% don't. But that's what we call a cognitive bias, is that I'm going to be the winner and not the loser. And if you actually start playing this game with the therapies, so this is an estimate, it's a figure, but when you look at tier 1 therapies, after about a 4-year period, 4 out of 5 will need to have more effective therapies. So only about 1 in 5 people will be responders. In other words, will have no evident disease activity over that period. What you're doing is, when you're putting everybody in tier 1, is that you're exposing the majority to undertreated MS for a 4-year period, and it has consequences. You saw the brain volume loss that occurred on interferon just for 2 years. Can you imagine that happening to 4 out of 5 patients, to find the 1 out of 5 that's a responder? When you go to the second tier, it improves. It's probably about 40 to 50% of people will respond. But again, half or the majority of people will be failing that treatment. And it's only when you go to tier 3 and 4 do you increase that responder rate close to about 4 out of 5 patients. And so that's why I always ask the question, if you had MS, which tier would you want to be in? And I think this is about population health. If you want to maximize the outcome of 100 people with MS, you would put them all on the high efficacy therapy. And some people, unfortunately, will have consequences because there will be more risk associated with this. But you're benefiting the majority rather than the minority. And I think this is where we are at the moment. Anyway, we've got some refuseniks. I call them the refuseniks. There are some neurologists in the UK, and probably outside, who are now refusing to use alemtuzumab. I don't know if you know, but alemtuzumab has been NICE approved. It's got a green stamp next to it. HSCT is also approved. So they're both therapies available. And under the Act of Parliament that created NICE, okay, we have a legal obligation. It's actually a legal case. We have a legal obligation, if somebody's eligible for therapy, to talk to them about it and offer it to them. And a lot of people who have very active, rapidly evolving severe MS are not even given that option anymore, okay? Because the neurologist looking after them is not prepared to take on the risk of treating that patient with that therapy. And that's the biggest problem we have in the adoption of HSCT, in my opinion, is actually the medical profession, the neurology profession is so conservative. They're not prepared to take on that risk. And so the question then is, who should decide on which tier of therapy that should be given. And we did a survey. This was way back. This is an old survey, and I'm sure it would have changed by now. And the majority of people with the disease, this is a social media thing on our blog, most of the people who read that would think that the neurologists are too conservative, okay? 84% came back and thought. That's actually quite a scary figure, and I wouldn't be surprised if they're asked now in 2023 we get the same result. Similarly, the majority of people who are reading the blog thought that HSCT should be available first line. Okay, it isn't available first line at the moment. To get it first line, you have to go into the STAR MS trial, or you have to go and find it yourself in the private sector, or go abroad, and so that actually creates inequity in the system. So hopefully the STAR MS trial will change this, and we will be able to provide it at least as an option for people with more active disease first line. And who should take on the risk? And it was quite clear, the person taking on the risk is not the clinician or the healthcare professional. It's got to be the person with the disease, and I think that's pretty obvious, okay? And we've highlighted this quite recently, and this has just come out in a publication this week, actually, about this issue of gaslighting. Gaslighting is when we, the medical profession, ignore what people with MS say. It's not only about their symptoms, but it's also about making a decision around which treatments that they want. And this was actually a really sobering survey we did. We had over 400 people with the disease respond to it. And it was pretty scary how many people had been gaslit. So gaslit is when you ignore somebody's complaints or whatever. It's like a psychological, okay, and the medical profession is pretty bad at this. And this was highlighted particularly during COVID, with long COVID. Most people in the early days of the COVID-19 pandemic who developed long COVID were ignored. I think they're still being ignored by the medical profession. Just to say to you, though, when it comes to smoldering MS, there are things you can do that are outside of MS, okay? So the brain is an organ that needs to be looked after. In the same way you look after your bones with bone health, the same way you look after your gut with gut health, the same way you look after your heart with cardiovascular health. There's a concept of brain health, and we now know that certain lifestyle things like not smoking, not drinking too much alcohol, exercise, particularly high-intensity exercise, diet, sleep hygiene. Sleep's a big one. I think that's the elephant in the room. The majority of people with MS have sleep problems, and we now know that poor sleep is really bad for the brain. Okay, it puts you at risk of dementia. Almost certainly, if we do the research, we're going to show a poor outcome in people with MS as well. And there's a whole lot of other things that happen in MS around recurrent infections. We use anticholinergic drugs to help you sleep, to treat your bladder, and they're associated with a big impact on brain. Okay. So one of the old drugs for the bladder, oxybutynin, Okay, reduces your IQ by about a half a standard deviation, 7 points, which is an enormous hit if you're working in the knowledge economy. So if you want to look at your medications, there's a calculator online where you can calculate your anticholinergic burden, and if you've got a score, I think it's above 2 or 3, you've really got to sort out your medications. The big one is amitriptyline. Okay, how many people in this room are amitriptyline? Yeah, quite a few, but it's also probably in the same ballpark as oxybutynin. And then the other one that has been highlighted in COVID is social determinants of health. And the WHO has just put out a big warning about social isolation, loneliness, and reduced social capital, which is your network of friends and family, are such important predictors of poor outcome, not only in MS, but in almost every disease you look at. And some of the social determinants are modifiable. You know, we as neurologists don't have access to them, but we can signpost. And the NHS has put in place about £500 million, £500 million, into what they call a social prescribing budget, where if you pick up somebody who has got social isolation or loneliness, you can at least give them a link worker and refer them into community-based services to try and help them. That's something we've got to work on. So to conclude then, I always end up with a story of my father. My father actually, he didn't have MS, but he had an end-stage kidney failure as a result of a condition probably called IgA nephropathy. It was an autoimmune disease of the kidney, and he was missed. So he ended up at the age of 39 on dialysis after presenting with malignant hypertension, high blood pressure. And he had an episode of hematuria a few times when he was in his late teens. It was ignored by his family doctor. So by the time he got to the nephrologist, all they could do was dialyze him. His kidneys were shrunken and end stage. And he had a peritoneal, then hemo, and then he had a transplant. But the nephrologist said to him, it's pointless coming to me now when you've lost the end organ. You know, I would have loved to have seen you in the beginning of your disease when we could have tried to modify it. And I think that's the advantage we have in MS, is we have a sentinel event. People come at the beginning of the disease or relatively early on in the course of the disease where we can protect the end organ. And I think that has to be our strategy in MS, is to try and get people as early as possible an end organ. I've got 5 minutes, okay? And the good news is the analogy I always use is rheumatologists, people with rheumatoid arthritis. It's the same as MS. They get a sentinel event. They present with their swollen, stiff, painful joints, and they get diagnosed relatively quickly. And the rheumatologists have got a 3-month window. They talk about that early window where they've got to suppress all inflammation before they get any joint damage, because once they get a bit of joint damage, a little bit of joint damage, they know that those joints will fail in 10, 15, 20 years. Okay? So that's why we are copying what rheumatologists do. They treat this condition so aggressively, and they've been so successful. Okay, the need for joint replacements has dropped by 85 to 90% for rheumatoid arthritis patients. So it's like walking sticks or wheelchairs in MS. You know, we should see the same results if we treat MS the same way rheumatologists treat rheumatoid arthritis. Okay, we don't do that yet, unfortunately. Very few centres in the UK, and I'm being honest with you, very few centres in the UK have the resources, number of neurologists, number of MRI scanners, and the licensing of these drugs to manage MS the way the rheumatologists manage rheumatoid arthritis. So I don't think our results at this point in time will be as good as theirs. But HSCT is one of those things we need, because not everybody will respond to our tier 1, 2, 3 therapies, and they will almost certainly need tier 4 therapies. And I've just made the point that we need the tier 4 therapies at the beginning of the disease. So the conclusion then is, are you prepared to allow your neurologist to gamble your brain and spinal cord? I think we need to go way beyond treating focal inflammation. And in MS, we're very fortunate to have a sentinel event, and I think we need to appreciate the natural history, what happens to this disease. Even though we've changed the natural history with therapies, we need to flip the pyramid. And I personally think that we can cure this disease. I'm fortunate enough to be in this profession long enough to have a cohort of people that had Campath, actually. I sent a few of my patients off to Cambridge, where they had the compassionate use campath, and they are close to 20 years later completely well. Okay? Relapse-free, MRI activity-free, fully functional, with no evidence of smoldering disease. So I do think we can treat smoldering disease if we hit this disease early. And I would expect, based on my reading of the HSCT data, I don't have that experience, if we've got a similar cohort of people who had HSCT are also now 20 or 15 plus years free of disease activity. And I'll take questions. Thank you very much.
Hi there. I was diagnosed in January and was really fortunate that Dr. Roos gave me HSCT in May. But my neurologist, I'm from Scotland, so it's Aberdeen Royal Infirmary, and basically he was really dismissive of HSCT and didn't tell me about it. So I guess my question is, why are people from Scotland especially not being able to access HSCT, even though it's like an approved treatment, if we want to be able to do it? And why are we not being told about it? I guess that's...
Well, I suspect you're not told about it is because it's not a first-line therapy. But as far as I'm concerned, it is available in Scotland, but as a second-line rescue therapy. Dr. Hunt, Professor Hunt's over there, it is available in Scotland, is that correct?
I don't think anyone from Scotland has managed to get HSCT, though. Okay,
yeah. But that's actually a problem then if it's available on paper, theoretically, but it is an access problem. And I'm looking at Professor Sharrock here. In the UK, there's probably less than 10 proactive centres with HSCT, or maybe 5 or 6 very proactive ones. He's shaking his head. So even in England, where we've got 68 or 70 MS centres, it's a handful that are proactive around referral for HSCT.
What's been done to kind of make neurologists more aware of that it's a successful treatment?
Yeah. We have meetings, we discuss this, etc. You know, I personally don't think HSCT is the ultimate solution. I think we need to work out how HSCT works. I think we've got some ideas about how it works, and it may be a sledgehammer, and we may be able to learn from HSCT and create safer therapies that are as effective. And I think that's got to be our. And I think part of the STAR MS trial is to try and work out how it works. It is a bit of a sledgehammer because it's quite, in terms of how it works, it's quite a blunt instrument, and I think we need to be a little bit, I think maybe in the future we'll have much better therapies that are targeted and could be as effective as HSCT.
Okay, so I had my first episode in December and I was diagnosed in February. When I was diagnosed, I was told, let's just wait and see how things go, have another MRI in 3 months' time. I'd continually relapsed from February right through until I had HSCT with Andu in Mexico in June. And they couldn't stop it. They made me steroid dependent. They kept pumping me full of steroids. Every time I came below 25 milligrams, I kept relapsing, and yet nobody could help. So where were we going to go had I not gone to Mexico? What was going to happen?
So we have in our centre now, because HSCT, by the way, one of the biggest hurdles is the time. And we find it very difficult to get people transplanted within 6 months, or within 4 months. It's usually between the 4 and 6 months it takes us. So that to me is too slow. So what we've been doing is we have this protocol where we put people on a drug called natalizumab Tysabri. It's the fastest working therapy we have, and it's a holding therapy, and it works incredibly well in suppressing activity while we make decisions later on. And we're actually testing that in a trial at the moment, just seeing if starting natalizumab Tysabri 3 months earlier, within the first few days of presenting, versus starting 3 months later makes a difference. And I'm almost convinced in a very active population, just 12 weeks of starting a therapy earlier will have a big difference for individuals.
Well, I was offered Octavis after arguing with my neurology and saying I can't go to bed every night to wake up wondering whether I'm going to be able to walk or not. And I would actually only started on Octavis due to all the tests and how long they take 3 weeks prior to going to Mexico. So,
Yeah, we're trying. I mean, there's a big group of us in the MS space that are trying to promote. That's why we do those policy documents, Time is Brain. And now we want to get the second one about flipping the pyramid. So time does make a difference, and the effectiveness makes a difference. But it's a slow process. There's a thing called the adoption curve, how quickly or slowly people adopt new innovations. And the neurologists have an incredibly slow adoption curve for treatments. Okay? And I think the UK is probably an outlier even amongst countries in terms of how quickly we adopt therapies for. I say that though, but looking at the latest figures, the UK is probably transplanting more patients than most countries in Europe now. Is that correct, Basil? Between us and Italy. Yep. Between us and Italy in terms of HSCT in MS. So what I'm trying to say is there is a process of, it'll take time. It takes time for people to adopt new ideas. Yes. Move.
Yeah. Mine is more about, I've had HSCT, my dad died from MS. I want to know what I need to look for in my children. We live a completely clean diet, but my kids are kids, they need to live. But my fear is that my husband's aunt also died from MS, so we carry the autoimmune disease really highly. They're saying stop it before it happens. Is there anything we can do to stop that?
The only thing you can do, there are some, the so-called modifiable risk factors is they shouldn't smoke.
They're 10 and 11,
so
hopefully not.
And you've got to protect them from childhood and adolescent obesity, so that, those two risk factors are probably about 1/5 of the MS population. And the big, I'm almost certain that EBV causes the disease. Yeah. You can't stop them getting EBV, but there will be vaccine trials starting very soon, probably at a population level.
Do you think that will be a young
No,
vaccination?
Our plan is to develop the vaccine to prevent infectious mononucleosis, glandular fever, as some people call it, because that's an important risk factor. And by doing that, we may be able to prevent some people getting the disease. The problem is we'll be doing the vaccine trial. The vaccine will likely get licensed if it goes according to plan, to be given with the HPV vaccine, Gardasil, which happens at 12 and 13 years of age. Yeah. And by that time, most people are EBV positive already. But we don't know yet. We've got to wait for the trials. But in 20 years' time, I might be standing here.
Hopefully the drugs will be so good it'll be fine.
Yeah, there's nothing else you can do.
Yeah. We are very careful.
Let me say to you, though, the majority of people with the risk factors for MS don't get MS. It's a minority. So there's some other factor. There's some bad luck, basically.
Yeah. Well, you can't live a stress-free life either. Yeah.
But they're living in an era where we've got much better treatments, okay? And the prognosis, and you've got skin in the game because you've got such a strikingly positive family history. And I think you're much more likely to, and this is why we need people like you to help us convert the community into a vaccine trial. I don't know if you're aware, but in the United States now, for example, about half the population, close to 50%, are against new vaccines. Okay, so we probably need vaccine hesitancy because to test those who have and have not had the vaccine in terms of outcomes. But in the long term, if the vaccine works, we really need people to have vaccines against EBV.
Just a quick question. So this is around the gambler's dilemma that you spoke about earlier, around the gambler's dilemma. And I guess my question is, what's apparent today is that for people with MS, their treatment is almost like a sort of high-stakes game of chess where you've got different moves, different treatments available. If even the tier 3 treatments like Tysabri, etc., are still causing brain atrophy, are still causing PIRA,
they're not causing it, they're just not good enough to stop it.
They're not addressing it. So they're not addressing it. Sorry, let me rephrase.
To be fair, they're addressing it partially.
Yeah.
So brain volume loss on those therapies is lower than you would if you didn't have those therapies. Yeah. But it's not good enough.
Yeah, exactly. Well, if it's not good enough, at the moment, do all roads lead to HSCT? Because even if you're on these high efficacy therapies, but there is an element of atrophy, there's an element of progression independent of relapses, is HSCT at the moment the only road that's going to kind of fully address those?
No, so I think I didn't talk about it, but there's very good data around another immune reconstitution therapy called cladribine. When it's used in the very, very early stages, people with clinically isolated syndrome, their first attack, their brain volume loss is also in the 0.15 bracket. So there are, I mean, at a population level, we cannot use, there's no way we're going to be able to roll out HSCT to everybody with MS. It just wouldn't. I'm not sure it's indicated for everybody with MS. I would need to see really good data to convince me of that. You know, the adverse event profile in terms of fertility alone will make it impossible to do that. I think, you know, we as a community would say it should be available for people with rapidly evolving severe, so the same kind of population that could get alemtuzumab first line, natalizumab first line, should be offered HSCT first line. And depending on you know, can we make it safer? I think unlikely with the current protocols, and this is why we need to know how it works. Cladribine is actually a much safer drug to use, and I think at a population level I'd feel pretty comfortable putting everybody who had first attack on cladribine based on a safety profile. And we may achieve similar results with cladribine. And it's CNS penetrant, that's the other advantage of cladribine. But we've got to convince the funders, we've got to convince the NHS to do it. You know, it's unfortunately, I mean, there are a lot of political hurdles around how the healthcare systems work and how funding works. Our biggest problem with HSCT is capacity. You know, we are trying to, every time we get a slot, we're potentially delaying a cancer patient getting the treatment. And because those units are run by oncologists, they have their specialty is oncology, and they want to put their patients in before us. And this is our problem. I was just talking about earlier with our CAR T-cell program. When we want to start CAR T-cell, is that our units don't have capacity for CAR T-cell trials because there's so many oncology patients. Bottom line is the NHS needs to triple their capacity in the bone marrow transplant units. Maybe even more. Triple? Triple?
Probably
at least triple. Because there's going to be an avalanche. I think there's going to be an avalanche of these cellular therapies coming not only to MS but other autoimmune diseases, lupus, myasthenia gravis, a whole lot of other autoimmune diseases that will respond to these treatments. And we're going to have to, I think maybe neurologists should start units. I don't know.
Okay, we've got one last question, a quick question, because we've got a break for lunch. So, Dr. Burt.
Oh, hi. It's actually not a question. I just also wanted to follow up on the comment of, how do we change? How do we get neurologists to notify people about this? How do you get access to it? And from my perspective, I have shared that frustration for 35 years. I never thought, after 10 years of animal work and all these clinical trials, that it would still be ignored out there. It's kind of unbelievable. But that's why I wrote the book, Everyday Miracles. Please get it. Please spread the word, because the only way it's going to change now is from the bottom up. The patients, you have surrendered your health care to a system that's made you a number, and they're not responding to you. It is failing. My patients feel the system in America is failing. It's extremely expensive. Suffering a chronic disease is acceptable. It's not to the patients. You have to fight to take it back, not surrender it to others. I wrote that book to help you. I'm on your side, but I'm a part of the system, and I have to work within that system for that respectability. I've provided the data. It's being ignored. In the last chapter of my book, I give a non-political explanation why that's happening, and that shouldn't upset anybody. The system needs to change. But right now, the only solution I can see, because I share that frustration every day with your patients, having worked to develop this field, is you're going to be the ones that have to change it. And so, and unfortunately, national societies like National MS Society have been very, very slow to change. So it has to be grassroots organizations such as AIMS or others that do this. I'm like, I've done everything I can. At this point, if nothing happens, well, I don't know what more to do. So it's in your hands.
I mean, what the MS community needs to do is what the HIV community did in the beginning of the AIDS pandemic. Okay, they got health policy changed by being activists.